have with us Dr. Kenneth R. Pelletier to share with us his valuable experience in workplace health promotion. Dr. Pelletier is a clinical professor of medicine at the University of Maryland and the University of Arizona. He is also a medical and business consultant to the U.S. Department of Health and Human Services, the World Health Organization, the Washington Business Group on Health, and major corporations including Disney, Merck, Ford, and Microsoft and Qatar. Indeed, we are honored to have him here with us today to speak on the topic of healthy people, healthy business, documenting clinical and cost outcomes by linking health and productivity, something which I'm sure is very close to the hearts of all of us present here today. It is now my pleasure to invite Dr. Kenneth Pelletier. Dr. Pelletier, please.
Well, good afternoon. Thank you for the invitation to the Health Board to be here. It really is an honor and a pleasure to be here and to assist in your efforts in the health promotion area to improve both health and productivity and performance. If there are two messages that I would like to convey, one is that this is a real and tangible, demonstrably effective approach to improving health and for creating a return on investment. That I hope to demonstrate very clearly so that you recognize from the corporate business sector point of view that there is a return on investment. This is a major part of the attempt of any business in any country, anywhere in the world, to be competitive, to be effective, and to be successful. And that is very important. The other is a caveat or a apology. I'll be referring, if you will, to a number of some data relevant to costs in the United States. And I do that because I can barely understand the complexities of the interaction between medical and cost issues in the United States, much less in any other country. But the important factor that I want to underscore is that however the financing takes place, and there are many, many different models. I know there are models that are different here in Singapore. There are also models that are developing and evolving that are actually very similar to some models that have been developed in the United States. But the important factor is it is never free. In some manner, medical care is always paid for. So it may be from the government, it may be from the individual, it may be from the corporation, but it is never free. And therefore, we need to find who are the stakeholders, who are at risk, and therefore who can intervene and implement these changes with us. So those two phenomena, I think, are very important, that it is never at no cost, or it always involves cost, and that this is a very real and robust phenomena. With that, we could end the lecture. So now I'll fill in the gaps. So we can have the first slide, please. I think I have I'll use this. Okay. This is simply to point out, and I apologize, I can only point at one screen at a time, but this is simply to indicate the sources of the information I will provide to you, that this is through the Stanford Corporate Health Program. We've had a 16-year program of working with large employers to demonstrate the clinical and cost outcomes of intervening in basic health promotion and disease management. We use this for our own employees. Stanford University actually has 24,000 employees, so it is a major employer. And these programs we implement within our own population. And the other is HealthNet, which is the fourth largest integrated provider of care in the United States. I'm on their board of directors. So I'm used to looking at this from the point of view of a director of a corporation, a provider, medical provider corporation, thinking, does this make sense from a purely business point of view? So these are the resources I want to draw upon. And the emphasis is on managed care. Managed care must address both the clinical and cost issues. And again, that is something to bear in mind. Some of these slides I'm going to go through very quickly, others I'll dwell upon a bit. Now, this is, I apologize for the complexity looking of this slide, but it's a very critical factor. If you look at the top right-hand bar graph, the United States spends about $4,000 per person per year on the provision of medical care. And then compared to the 20 predominant World Health Organization participating members, if you look at the very bottom is Greece. Greece spends $400 per person per year, or 1/10 of the annual medical expenditure per person per year of the United States. Now, the lesson from this is that on every internationally accepted measure of health, based on the World Health Organization indicators of health, Greece ranks higher or better than the United States on every single measure of health, at 1/10 of the annual expenditure. Now, someone might say, well, that's an artifact. It must be the olive oil or the Mediterranean diet or the beauty of Santorini, whatever it is. But every nation between Greece and the United States ranks higher or better on the majority, if not all, of the indicators of health. To me, the critical lesson here is that attaining health for the population as a whole is not a matter purely of finance. It's a matter of appropriate allocation of those financial and medical resources. That is very critical because clearly other nations are doing a much better job than others. Now, one of the driving forces, both in the United States and certainly here in Southeast Asia, is the aging of the population. We all know that as the population ages, medical costs increase exponentially. If you look at the United States, we're going to experience perhaps about a 100% increase in the population over age 65, roughly in the next 20 years. But if you look at Indonesia, it's over 400%. And Southeast Asia, again, as you know better than I do, is one of the more rapidly growing aging populations. So the challenge is, if now medical costs are a burden, how are we ever going to meet this rapidly escalating and aging population? And this is, again, the increase. You look at age 80 to 84 and the enormous escalation. It goes from roughly less than $500 for infants to $12,000 to $13,000 for people over the age of 80. So this is an inexorable driving force on every company, every population in the world. Maybe what I can do is just say next. It seems to be faster than this mechanism. Now, this is an important slide, and again, this goes back to the United States, but it illustrates a very important principle. In the year 2000, the United States had the dubious honor of crossing the $1 trillion annual expenditure for medical care. It stood at that should actually be a 1. It's $1.2 trillion in the year 2000. If you look at the red area under this curve, this is very important for the business sector. Think of the fractions that we all learned in school, the numerator and denominator. The denominator is after-tax corporate profits. That's the denominator. The numerator is how much those same companies spent for medical care for their employees, dependents, and retirees. For the average Fortune 500 company in the year 2000, the result of that fraction is 61.2%. In other words, the average Fortune 500 company, many of whom are based here in Singapore, many of whom we've worked with, IBM and Hewlett-Packard, Motorola, the average company will have spent an amount equal to 60% of its after-tax corporate profits to just meet the medical care for its employees, dependents, and retirees. That is astounding. That is an adverse effect because those dollars add to the cost of every product and service. It makes whatever you are producing less competitive in the global marketplace. So this is applicable across the board. Hey, next slide, please. Again, this is a bit washed out, but there is a dinosaur. I'll accept the identity. And other dinosaurs. And the dinosaur is saying, the picture is pretty bleak, gentlemen. The world's climates are changing. The mammals are taking over. And we all have a brain about the size of a walnut. I think if anyone's in medical care anywhere in the world, you can't help but feeling that way these days. Okay? Next. Now, this is perhaps to me one of the most alarming. The blue, although I believe it looks blue, the blue bar graph is the average rate of inflation for everything. Provision of raw materials, salaries, infrastructure for a company. The red line is the impact of managed care on medical costs, which at least, again, in the United States, reduced this rate to a very low level. The problem is none of these were all essentially cost-cutting. These are economic measures, barriers to access to services, and other kinds of purely economic interventions. The problem is they did not at all change the fundamental issues of risk factors, of health promotion, and of disease management. What we are experiencing is that at the present time there is now 10% rate of increase again. That is expected to increase to perhaps 15 to as high as 20%. And there is little, if any, hope of changing that rate of increase in the near future because all of the purely economic and legal barriers have been exhausted. That's by and large what we've called managed care. Now we have the difficult issue of addressing risk factor and the true establishment of health. Okay, next. So this is what we've been going through. It says, breathe deeply and take a quick look at my bill. So whether we're private, I used this at a medical conference, and it was a long, narrow room, and someone in the far back said, who's saying that? So it depends on if you're a company or a provider as to who is making the statement. But when any of us receive medical care, we're all faced with the same reality. Okay? Now, these are what is responsible for this escalating cost. These are universal. One are new pharmaceuticals. They're expensive. Pharmaceuticals are the one major driving force in the cost of medical care. Again, pharmaceutical costs are escalating at the rate of 25 and 30%. Now, I am not saying pharmaceuticals are bad. I am not laying blame. In fact, most of our research actually uses pharmaceuticals in a new behavioral domain. So you may, in fact, spend more for pharmaceuticals in order to yield a better effect. But in the short run, it is an increase in cost. The population aging, it's a global phenomenon that's going to affect all of us. And finally, technological advances, again, an inexorable kind of development. These are the new areas that are really driving those figures upward. Okay, next. Now, this is an important point. As was noted in the introduction, here are the major causes of disability. And in fact, here in Singapore, rather universally, heart disease, cancer, cerebrovascular, i.e. stroke events, are usually the major areas of cost. But what I want to point out, I want to make it a very important distinction. These are not the causes of death. These are what the pathologists tell us post-mortem. This is what the person died of. But these are not the real causes. The real causes are the factors on the right. And this is based on the U.S. Department of Health and Human Services and the Centers for Disease Control. It was published in the Journal of the American Medical Association. The heads of those two respective organizations said, let's step back and think about what is driving these diseases. And they came up with tobacco. This is in order of significance. Tobacco, diet and inactivity, alcohol, certain infections, toxic agents, firearms. Fortunately, you don't have that problem here. We do. It's a dreadful problem. Sexual behavior, motor vehicles, and drug use. Again, these are the cause of death. Therefore, these are modifiable. What's important to realize is all of these can be changed. And as I understand the objectives of your health promotion efforts, it is to address, modify, reduce these factors. And I commend that. It is really the only way we're going to produce health as opposed to increasingly managing disease at an escalating cost which becomes unbearable. Okay, next. I want to add one other In this list, although that is as formidable a list as I have ever seen, they completely overlooked pharmaceutical interactions. And again, if you look for 1998, that there were 106,000 deaths. It makes it either the third or fourth leading cause of death is deadly drug interactions, and that is a virtually entirely preventable event. And we are doing some research and developing computer systems for monitoring and flagging deadly drug interactions. 43% of these actually occur in the hospital setting, which is really dreadful if you think about it. Now, if you add this to the others, you find that the vast majority of those diseases and fatal events for which we are paying enormous expenditures are preventable in total or in part. That is very important. Okay, next. So this is the situation. I'm afraid we don't have any medications to improve the quality of life. To some extent, we are reaching the limits of what we can do pharmacologically and surgically. These are really lifestyle changes. It involves behaviors and attitudes and appropriate use of pharmaceuticals, but we are really faced with how to change behavior. Okay. Now, this is a program which has been in place for 16 years. By the way, that's all the doomsday information. We know more. From here on, it's what are we doing about this? How can we begin to address and resolve this issue? We have had a research program. Our entire focus since 1984 has been to develop and evaluate innovative programs focused in work sites that improve the health, well-being, performance, and productivity of employees and corporations. That's what we do, and to demonstrate the database for doing so. It's town and gown in the sense that it is applied with full academic rigor, but it is also practically applied in work sites. Okay. Next. So we're looking at the relationship between global health and individual health. And it is very predictable. During times of economic downturn, which we have all experienced globally for the last 2 years, there is an unequivocal increase in chronic and acute disease of all kinds. Depression, heart disease, cancer, arthritis, musculoskeletal disorders across the board. These increase 2- and 3-fold. Now, what is even more fascinating to me is that when you have a dramatic increase, which presumably will happen and hopefully soon, in productivity and performance, there is a commensurate increase in such illnesses and diseases. So adaptation, the difficulty in adapting to extreme circumstances is, through the vehicle of stress, is inherently conducive to problematic health injury. Okay. Now, these are just simply to point out some of the members of the companies that we work with, and we have worked with now for 16 years. Again, Disney, Hewlett-Packard, IBM, Motorola, Levi Strauss, the infamous Levi manufacturer, Xerox, so also Shackley and Yamanouchi. So we have worked with these companies focused on very practical issues, and I'm going to show you the results of those interventions. Okay, next. So this is two bears. They're talking to each other. There's a man hanging in the tree, and he says, his name is Bradshaw. He says he understands I came from a single-parent den with inadequate role models. He senses that my dysfunctional behavior is shame-based and codependent, and to let my inner cub heal, I say we eat him. So no matter how elaborate are our theories, no matter how complex are the interventions, what we need to look at is what is the bottom line. Does this improve performance? Does this return on investment? The answer is yes. Okay, next. This is one example. I just want to make this very concrete. SCRIP stands for the Stanford Coronary Regression Intervention Program. In a 5-year study, we were the first group to demonstrate that you could use a telemedicine-based intervention. You could use nurses and physicians using the mail, telephone, and computers with high-risk patients. These were all patients who had been referred for coronary catheters, for possible angioplasty or invasive procedure, and we conducted an intervention using the mail, telephone, and computers, and we're able to demonstrate that we did not have any surgical procedures required in 5 years. We were able to reduce the number of events, or meaning everything from hospitalization to death, by half, and we were able to deliver the intervention at 1/10 the cost of usual care. And we also had pre and post measures of the actual angiogram from our patients and demonstrated an actual regression or improvement of heart disease. But that's the basic research. Blue Shield, which is one of the largest health care providers in California, heard about our study. They said, now that's fascinating. General Electric is one of our clients. They have a major heart disease problem. We are having to increasingly raise their premiums in order to allow them to have such a high incidence and for us to remain their insurance carrier. Do you think we could intervene with GE and develop a model we could then use for our other companies? So for 2 years, we did intervene with General Electric, and were able to reduce the coronary heart disease risk by nearly 50%, incidence by as much as 1/3, reduction in overall heart disease. So the benefit to Blue Shield was a new program they could offer not only to General Electric, but to other corporate clients. For General Electric, they were able to actually lower their premiums and disability payments to allow other monies to go into development, salary increases, et cetera. So that's an example of a very practical intervention that we've conducted. We've subsequently now taken that same program and have implemented that with American Airlines. So that's just a very concrete example of what I'm referring to. Oh, good. Okay. I just got 5 minutes more time. Lucky me, bad for you. Okay. Thank you. And so if we could just back up to one. So other areas are women's health. We have actually a 12-year program focused specifically on women's health issues, focused on heart disease. Heart disease is quite different in women than it is in men. Cancer of all sites and osteoporosis. And I, again, in one of the companies I visited this morning, I know that osteoporosis has been a focus for that company. I think these are excellent. We're also looking at what we call alternative medicine, which is really the use of much of what is in fact indigenous medicine to Asia, traditional Chinese medicine, acupuncture. These are actually of great interest to the U.S. corporations because of the demand of their employees to their unions and as individuals. So we're doing a great deal, and I'll give you an example later of actually an intervention we're conducting with Ford Motor Company using acupuncture, acupressure, and herbal anti-inflammatories. VDT-related or carpal tunnel injuries, common among information processing and high-tech industries, fracture intervention, breast cancer prevention. So these are some of the areas in which we've conducted our programs. Okay, next. Said the good news, Mr. Ferguson, a team of medical experts think you're well enough to see your bill. Important point being that with all of our companies, we are very explicit. If they say, we want to save money on medical costs, we say, well, you really should talk to attorneys and accountants. That's not our expertise. However, if you want to improve the health and well-being of your employees, their dependents, and their community, and in fact, that will result in significant cost savings and return on investment, then we're in explicit agreement. And we make that very, very explicit with all of our companies and want to emphasize that. Okay, next. We take an approach which is total medical costs, and this begins to link the explicit measures of medical cost, health, and productivity and performance. It's rather like the difference between salary and total compensation. We're interested in the total impact of disability, the total impact. And this is one of our companies who actually has a $1 billion annual expenditure in medical care. They estimated 200 million of that to be direct medical costs, payment to physicians to provide services. Another 200 million is short-term, long-term disability, workers' compensation, family leave, personal days. But the remaining, actually larger figure, which is as yet undefined, and we're working with them to do this, is then in the form of lost sales, poor customer services, reduced level of service, replacement workers, employee turnover. When you begin to factor in these elements, then you see really what is the total cost to a company in a very practical way of decreased health among their employees. Okay? These are 5 articles, and I believe I think from the Health Board you could certainly receive them. They're just reviews of the literature. I'm going to show you in one slide everything that's in these 5 articles. Okay? But those are the references going back now, reviewing the literature in this area about every 2 or 3 years, looking back over 25 years of documentation of such studies. Okay? Next. So this is the summary. These are the Reader's Digest notes. The time periods from 1980 to the present. In that time, there have been 117 studies conducted in work sites looking at both the clinical and cost impact. There are comparison groups or a structured study for 93 of them. There are 45 clinical trials. This is the gold standard of research in any given area. And they range from 6 months to as long as 12 years. The 6-month study is actually one that we conducted. We conducted the first study that brought a mobile mammography unit from our medical school to Levi Strauss. And we demonstrated that you could screen a larger number of women more efficiently and equally accurately by bringing a mobile van to a work site rather than having women one at a time leave the work site for a mammography screening. And 12 years is the Women's Health Initiative that we're engaged at the present time. Every single study of these 117 studies, every single one demonstrated a positive impact on health for a wider range of conditions. Of those that were analyzed, 78 of those studies were analyzed for return on investment and cost effectiveness. Of those, every single study demonstrated a return on investment or a return, except for one. And the reason that one did not is they factored in the cost of a $5 million fitness facility into the cost side of the equation. Now, I don't know who the economist was for that study, but that was a fairly predictable outcome that you're not going to save money on that. So I would say collectively, the basic lesson is all of them are, in fact, cost effective. Okay? Now, these are some of the other, and this is when we get into this other domain beyond direct medical, these are some of the other objectively reported outcomes. Reduced turnover, decreased absenteeism, which may not be a problem per se here in Singapore. Understand absenteeism is very low. But the question is, how productive is someone when they're present? And we'll address that in a few minutes. Declines in short-term and long-term disability, overall reduction in risk, return on investment, stabilization or reduction of medical costs, enhanced productivity, performance improvement, improved employee morale, recruitment and retention. These very often become significant ways in which to recruit new employees or to retain existing. And finally, increase presenteeism. And I'm going to show you a little bit of detail on that. The presenteeism is a positive, explicit new measure that we developed over 2 years to explicitly link individual and collective performance to cost, which is this kind of holy grail. It's this X factor. Okay, next. We developed the Washington Business Group on Health, which represents about 250 of the Fortune 500 companies, held a major national meeting about 2 years ago. The conclusion of that meeting is that we needed new metrics or new measures to address some of these factors that we know are important, performance, productivity, but we didn't have we didn't have objective measures that would convince a chief financial officer or a board of directors that this had merit, that this was tangible. And what they came up with was the term presenteeism. Merck Pharmaceuticals was one of the members of the task force, and American Airlines was a participating member. So Merck is one of our corporate members, came to us and said, we don't want this report to simply sit on a desktop. What we want to do is try to implement and operationalize this concept of presenteeism. So we engaged in a 2-year study, which we just completed and published in January of this year, and it was to develop and test the presenteeism scale to evaluate the impact of health problems on individual performance and productivity, and then you could collectively have that for a total work unit or a total corporate site. Okay, next. So these were the institutions at Stanford, University of Maryland. Merck was the funding agency. and Columbia University. So it was a multi-site study. Next. Now, absenteeism is, you can determine that. You simply count, is a person physically at work? And by and large, especially during hard, difficult economic times, absenteeism is usually very low. People are afraid to be absent. Presenteeism, on the other hand, is how engaged, how productive is a person once they're physically at work. And for high-tech industries, for those that require intellectual participation, creativity, innovation, this becomes actually more critical than when a person is present or absent. In fact, a person may be absent, maybe telecommuting, or using computers or interacting with their colleagues by distant technologies, and in fact be very present. So this is a different kind of measure, different kind of dimension. Okay, next. Now, these are 6 items. This is the actual presenteeism scale. Now, it looks deceptively simple. We actually started out with 32 items. And anyone that knows about research and testing, to have 32 items is easy. To have 6 items is horribly difficult. These 6 items were factored out over the course of 3 studies to be able to accurately predict presenteeism. It changes over time, and it is very sensitive to intervention. And what we did is basically a person states, because of my, and then fills in the blank, or you have a specific area you're interested in doing. You respond to these 6 questions, and again, we can make this available either in PowerPoint or in hard copies. So there's no need to copy down the questions. As an example, at work, I was able to focus on achieving my goals despite my. In other words, despite a distraction, I was able to focus or not. So we're looking at a health problem and its interaction with actual day-to-day performance. Okay, next. And you can substitute for health problem any word. Back pain, cardiovascular problem, illness, stomach ache, whatever the factor is, it can be plugged into that. To us, what was actually, yes, and it is equally accurate. We tested it out with a number of different conditions in different populations, and it's equally accurate. Okay, next. And they simply score it. 1, if you strongly agree with that statement, to 5, you strongly disagree. So it's a standard Likert scale, empirical, objective, used in many similar kinds of scales. Okay, next. Oh, and this is something we found that may be at the root of the difficulties in work sites. My mind and body hate each other, which may be the best definition I've ever seen of stress, which is the most ubiquitous problem in work sites. There was a very large study conducted at Citibank, the largest study of its kind, and they demonstrated unequivocally that stress was the single most accurate predictor of increased medical costs, reduced productivity and performance of any other factors for a population that was roughly 13,000 in number. So this is a very compelling factor. Okay, next. So our conclusion is that it has predictive characteristics, and it has supported the feasibility of using this in work sites to, again, link performance and productivity. At the present time, since it was published in January, is now in use in 35 companies, including Sprint, Eastman Kodak, Dow Chemical. So 35 corporations have already adopted this as an integral part of their ongoing measurement. So I think it's not as important that the scale is being adopted as that the principle, if you will, of presenteeism, how functional is a person once they are physically at work, is beginning to be accepted and embraced as a critical linkage. Okay, next. This is kind of bullet points. Given everything that we have learned, what I want to do is show you just a few bullet points of what constitutes a successful worksite intervention. What would be the essential critical elements? Many of these are already in place in your company. For those that are missing, you might decide to emphasize them. If you're just starting, it's a good place to begin to think about it. One is to conduct a structured needs assessment. There are many objective tools, but one of the most effective is certainly to poll your own employees. What do they think are critical issues? Involve them in the process. I know that there are actually very positive relations with your labor unions here, and I commend you for that. That is not always the case in the United States. Sometimes they are very supportive, and when they are, they're very effective. Other times, if they are not engaged early on in the decision-making, they can actually be very destructive to such an effort. So to engage everyone who's going to be affected by the program in the design, in the development of it. Secondly, build evaluation into the program. Even if enthusiasm initially is what allows the program to develop, at some point, you're going to have to justify in terms of cost and expenditure the economic return of that program. And if you don't build evaluation into the beginning, it's very difficult to structure later. These can be very inexpensive and maybe a way of involving, in fact, your academic community here in Singapore as part of the infrastructure for evaluation. The other is control groups. That could simply be another company within a given corporate sector, or a group of employees who are delayed in receiving the program. So it's some means of comparing so you know what you've done has worked and what has not. Obtain baseline data so you know where you began. Do you really know? You can assume that heart disease is probably the major factor. Some companies have actually been surprised. A major bank in the United States found out that pregnancy complications turned out to be its major cost factor. That was a surprise to them until they conducted a needs analysis. Standardizing your risk appraisal so that your data and information becomes comparable. This may be a very valuable thing to do among companies to pool your resources and say, what are we going to look at in common? Okay. Next. Determine data points. What is the information you're going to collect? This is often very, very difficult. Just deciding how to collect the information, what it means, how to assess it. Include dependents, retirees, and small or remote work sites. One of the reasons we are now using a telemedicine model is to take advantage of technology. You can reach individual workers anywhere in the world. You can reach small groups of workers. You can actually provide the same quality of program for a very large employer as you can for an employer of 10 or less. And that's the research challenge actually that is more representative of our common, direction for this next decade. Developing research, develop profile of high-risk areas. This is critical. There have been really three major trends if you look historically. During the 1970s, the emphasis was on basic health promotion to sustain the overall health and well-being of the population as a whole in a work site. Very positive, very commendable. I know the Johnson & Johnson Live for Life program is one of the early programs that were implemented here in Singapore. I was actually involved in a major way in the development of that program. Then during the 80s, people began to realize that that is a good foundation, but the major disabling and high cost centers are high risk. When someone develops heart disease, when someone actually has a diagnosis of cancer, when there is a pregnancy complication, where there's breast cancer or other forms of disability, unchecked hypertension, unchecked diabetes. And so the emphasis is to begin with health promotion, but build in a system so you can readily begin to identify those high-risk individuals which in the very near term are going to cost a great deal, both in terms of human suffering and finance. So that becomes an important strategy. And in fact, that's what is now occurring. That is the major focus, at least in US-based programs. Develop research designs, generate appropriate reports. You'd be surprised, I'm rather shocked sometimes that these elements are not included in quarterly management reports, or the data is not such that the management clearly understands the objectives and the fit of the health program with the overall corporate initiatives, and feedback procedures to design and to improve and evaluate the ongoing program. Okay, next. Now, what does the future look like? And these are the last two slides. What could we conclude from this? The majority of clinical trials demonstrate positive clinical outcomes. I want to emphasize that this is unequivocally clear. This is scientific evidence. It's not marketing. It's not sales. This is what the evidence shows us in rigorously designed studies, that there's evidence of positive impact across all types of business ranging from retail to high technology, banking, telecommunications, the computer industries. It seems it's irrespective of industrial sector, levels of workers, all the way from literally janitorial staff. Any number of interventions have been conducted such that they reach down into the very basic level to the senior management level. They can work effectively. There may be different resources allocated at different levels, but they can be effective. All income levels are, income seems to be independent of motivation on the part of the person, and nationality. I find these are effective across the board in European nations, Latin America, North America, and those companies we work with here in Asia. The clinical trials demonstrate positive cost outcomes. They do return on investment. And to me, a certain sign that this is a real phenomena is that the more rigorous, the more disciplined is the design and focused is the study, the better the outcomes. Now, sometimes that is not the case. Sometimes in science, the harder you push on a phenomena and design better and better studies, it starts to dissipate. It goes away. In this case, just the opposite is true. So I take great heart in that. Okay, next. There's a need to standardize and to operationalize these measures. The biggest challenge is not, to me, any longer whether this works or not in terms of medical outcomes, not whether it's cost effective, because both are clearly demonstrable. It is the specific application within your work site. That's the challenge, because every company thinks about this differently. And it's very important to determine how does this affect your business? Where does this add cost? There's the famous statement that Lee Iacocca made about Chrysler. He pointed out that the cost of medical care added more to the cost of an automobile than the cost of steel. Happens to be true. So within the automobile industry, when we have an objective outcome of a study that we're conducting, we look at medical cost per automobile. That's the standard. When we work with American Airlines, what we look at as one of the outcomes is how much does excess medical cost, or in our case, hopefully the savings, how much does that add or subtract to the cost of an airline ticket? Because that's their unit of competition, or per air freight pound. So we need to find, and once you find that metric, again, it goes back to who is at financial risk, how will they know you've made a difference, and how can you demonstrate and intervene to do that? This is universal. I'll give you one example of that. In the year 2000, Ford Motor Company spent $70 million for payment for low back pain and disability. That is pure medical expenditure. That's in category 1. That's not replacement worker time. That's pure what they pay for physicians and nurses to manage back pain. They have 12 clinics nationwide throughout the U.S. devoted exclusively to back pain. They're one of our companies, and as we talked with the medical directors, we said, we'd like to look at the protocol. What do you use for the management of low back pain? And they showed it to us, and I looked at it and I said, this is excellent medicine from about 1952. It's a really primitive way, largely surgical and somewhat effective pharmacologicals. So at their request, what we're going to do with presenteeism as a measure, with cost measures, we're going to intervene in one of their 12 clinics, beginning in January, using acupuncture, acupressure, non-steroidal anti-inflammatories, yoga, meditation and stress management, herbal anti-inflammatories. In other words, everything we can possibly throw at an employee with a back pain problem. And they know this is going to be inherently more expensive, but what we believe is that there'll be a more rapid return to work, less recidivism, and an overall global improvement by teaching these individuals how to sustain the future, or how to eliminate the future incidents of back pain that will in fact prove to be more cost effective than usual care. So that's a typical model, a typical kind of intervention that we're developing. Over lunch, the director of SNF said, well, can you send us that? And I said, well, in about 2 years, we'll know the effect of that. But that's how we design our studies. And there is evidence of a dose-response relationship. In other words, it may be more expensive and intensive initially, but it has a better outcome. And finally, to extend the duration, it's one thing to bring an employee population up to a certain level, but then it's another matter to sustain that effort. And this becomes important in terms of marketing, innovation, the creativity of the employees, and keeping people involved. I think there's one last slide, if I could. Okay, this is a little hard to see, but there's a figure of Moses. Yes, okay. Kind of parting the Red Sea, or this, in this case, a swimming pool. And it says, Moses' first and last day as a lifeguard. And what I want to conclude with is that if something works, it also has the potential to be harmful. We know that about every pharmaceutical and about surgical interventions. If it's powerful enough to work, it's also powerful enough to not work, or powerful enough to have an adverse effect. So we need to conduct these interventions, develop these programs with a great deal of thought. And my concluding statement, to really end where we began, is to just assure you, to whatever extent that I can, that this is a real phenomenon. There are lessons that we've learned from all of these studies. There are global models which can be applied to work sites. And my exposure, and what I'm looking forward to in this week, we're going to have some very intensive meetings where we're going to explore all of these areas more in depth. But I am genuinely impressed by the public-private collaboration that's possible here in Singapore. That is very rare. That really doesn't exist in many, if any, other nations. And I think that's very significant. And from everything I've seen in this short time of being here, I'm very impressed by your efforts, and I commend you, truly commend you. I think it's an unequivocally right direction. It will improve the health of your employees, your community, and I think ultimately it will ensure the viability and competitiveness of your business sector well into the future. And I know that's a major issue and a major concern, and I'm positive this is a right direction for you. And again, I want to thank you. It's been a privilege to talk with you. It's an honor to be invited, and I hope this has been of help to you. Thank you.
Thank you, Dr. Pelletier.
Thank you.